So good day. Again, welcome to Clinical Pharmacy and Pharmacotherapeutics 2, Gastrointestinal System Therapeutics. So for our disclosure and disclaimer, this presentation is for pharmacy educational purposes only. Some slides, presentations were taken from the teaching slides of associations, organizations establishing therapeutic guidelines. Any brands, proprietary products, devices mentioned in this presentation is not sponsored nor has intentions for commercial purposes. The lecturer is not affiliated to any pharmaceutical company or sponsors. Learners are also encouraged to perform their own assessment, research, and evaluation on the information discussed in this presentation. Further, this lecture is not a substitute to any direct clinical judgment. So we are now halfway through our discussion of the gastrointestinal disorders. So particularly, we are now going to focus on gastroesophageal reflux disease or GERD, and also to include peptic ulcer disease or PUD. So to begin with, gastroesophageal or esophageal reflux disease or GERD, as normally termed, occurs when reflux stomach contents lead to troublesome symptoms and or complication. So episodic heartburn that is not frequent or painful enough to be bothersome is not included in this definition. Although that is one of the most common symptoms being observed in this condition. So let's move to the pathophysiology of GERD. So the key factor is the abnormal reflux of gastric contents from the stomach into the esophagus. In some cases, the reflux is associated with defective lower esophageal sphincter or the LES, either on the pressure or function. Patients may have decreased less pressure from spontaneous transient less relaxations. Thus, transient increases intra-abdominal pressure or an atonic LES. So in that case, some of the foods and medication can decrease LES pressure. Now, problems with other normal mucosal defense mechanism may contribute to the development of GERD, including abnormal esophageal anatomy. We also have improper esophageal clearance of gastric fluids. Another is reduced mucosal resistance to acid, delayed or ineffective gastric emptying, inadequate production of epidermal growth factor, and reduced salivary buffering of acid. Now, esophagitis may occur or occurs when the esophagus is repeatedly exposed to the reflux gastric content for prolonged periods. This can progress to erosion of the squamous epithelium of the esophagus, resulting to erosive esophagitis. Now, substances that promote esophageal damage upon reflux into the esophagus may include the gastric acid itself, pepsin, bile acids, and the pancreatic enzymes. Composition and volume of the reflux state and duration of exposure are the primary determinants of the consequences of gastroesophageal reflux. Now, complications from long-term acid reflux or exposure rather includes esophagitis, esophageal strictures, Barrett's esophagus, and esophageal adenocarcinoma. Now, we have here a table that summarizes the different food and medications that may worsen GERD symptoms. For the food, we have like fatty meals, chocolates, coffee, onions, garlic, and they are attributed to decreasing the lower esophageal sphincter, LES pressure. We also have medications such as caffeine, nicotine, nitrates, tetracycline, estrogen, no, those are hormones. We also have those that directly irritate the esophageal mucosa, such as spicy foods, tomato juice, orange juice, because they are acidic, coffee, tobacco. For medications, we have aspirins, biphosphonates, NSAIDs, iron, potassium chloride. What else? And so just to enlarge the list, sorry. And then for clinical presentation, normally symptom-based GERD would present with heartburn. When you say symptom-based GERD, it can either be with or without esophageal tissue injury. So again, heartburn would be a typical presentation. And this is normally described as a substernal sensation of warmth or burning rising up from the abdomen that may radiate to the neck. So it may be waxing and waning in character and aggravated by activities that worsen the reflux. Like, for example, if we are on a recumbent position, bending over, or eating a high-fat meal. But in my own experience, when there's a increased heartburn in the presence of high-fat meal, another diagnosis to consider is the presence of cholelithiasis or stones in the gallbladder. Now, other symptoms, likewise, we have to take note of the heartburn because in many cases, this is also a differential diagnosis for persons having angina pectoris because the pain originates from the same area. So whenever we encounter patients complaining of such pain in the sternal area, we need to be critical to take pertinent information so as we can directly refer them to the appropriate medical consult. Then other symptoms may include the water brush or the hypersalivation, belching, and flatulence, and regurgitation, which is the reflux of the acid, especially at night or at dawn, and if the patient is on recumbent position. Alarm symptoms may indicate complications. So what are these alarm symptoms? This may include dysphagia or difficulty in swallowing, odinophagia or an inability to swallow. Means basically that would include also bleeding and weight loss. We can also look at tissue injury-based GERD with or without esophageal symptoms, which may include esophagitis or esophagitis, yung inflammation of the esophagus, esophageal stricture, so it decrease in the lumen diameter, Barrett's esophagus. So Barrett's esophagus is a condition wherein the esophagus is described as pink, or in the flat pink lining of the esophagus or the swallowing tube connecting the mouth to the stomach are damaged by acid. So usually the lining becomes thickened and very red instead of pinkish in color. Then we can also have possible esophageal carcinoma. So alarm symptoms may also be present and should be red flags for the assessor. Again, we are discussing this for information base, but the medical diagnoses are reserved for the doctors. Extraesophageal symptoms may also be present, such as chronic cough, laryngitis, asthma, and dental enamel erosion, especially if the acid has already refluxed beyond the esophagus and into the mouth. Remember that GERD also may cause nausea and vomiting in this sense. So for the diagnosis, clinical history is sufficient to diagnose GERD in patients with typical symptoms. However, perform diagnostic tests is still recommended, especially for those who do not respond to therapy or initial therapy, or those with alarm symptoms, as I've mentioned a while ago. Now, endoscopy is preferred for assessing the mucosal injury and identifying other conditions such as Barrett's esophagus and other complications. We also want to prevent further damage into the esophagus. That's why endoscopy is preferred. And ambulatory patient monitoring should also be done, which includes pH monitoring, esophageal manometry. We have also high resolution esophageal pressure topography, and empiric trial of proton pump inhibitors can also be warranted. Now, for the goals of treatment, of course, we reduce or eliminate the symptoms, as we have mentioned a while ago, decrease the frequency and duration of the reflux, promote healing of the injured mucosa in order to prevent severe complications, and again, to prevent development of complications. So for the treatment, based on the present, so on the signs and symptoms, so we have for esophageal clearance, we have betanicol. For esophageal mucosal resistance, alginic acid sucralfate. So the purpose of this they are cytoprotectives, and they also help in the production of mucose, and mucose lines or protects the esophagus from the erosive effects of the gastric acid. For LES pressure, we can have betanicol and metoclopramide. And of course, since the inflammation is triggered by the acid itself or the excess acid, so gastric acid regulators are also recommended as treatment. So we have antacids, we have the histamine 2 receptor antagonists, and of course the proton pump inhibitors. So these are the recommended treatment regimens. So for intermittent mild heartburn, so we have lifestyle modification, which includes, of course, avoidance of the possible triggers such as the food, medications that we have mentioned a while ago. And then direct therapy can be initiated, such as the use of antacids. The following are the choices. So we have Maalox, which is a combination of aluminum magnesium, Gaviscon, which includes, this is a brand, but it has several preparation that would include the presence of alginic acid. And then we also have calcium carbonate as antacid. Now, for other non-prescription H2RA, they are non-prescription in the sense that they have lower dosing being prescribed than normal. But nonetheless, here in the Philippines, I believe the preparation that we have with the non-prescription H2RA, although I sorry for mentioning a brand, we have the Kreml S Advance, wherein it's a combination of our antacid together with an H2RA of a lower dose as compared to the prescription drug. And then we can also have the PPIs, although here in the Philippines, proton pump inhibitors are mostly in the prescription form. We don't usually have the non-prescription. Okay, so just to highlight. Now, for healing or erosive esophagitis and others complication, it would require now a certain range of treatment with the PPI or H2RA. So that's roughly around 4 to 16 weeks. And of course, if necessary, interventional anti-reflux surgery may be recommended by the doctor. One important non-pharmacologic therapy that we can include is what we call the head elevation. So, well, technically, based on anatomy and gravity, in order for the patient during sleep, since acidity is at peak during night and at the early morning, so while the patient is sleeping, so in order to prevent the occurrence of GERD and also NERD, when you say NERD, these are nocturnal esophageal reflux disease. So in order to prevent that, one of the non-pharmacological recommendation is to have a elevated head position while sleeping. So here in the illustration, you can see the patient has an elevated head pillow, and also the orientation is to the left. So in order for the acid not to reflux back. So other lifestyle changes would include weight reduction, since some in many cases overweight or obese patients encounter this reflux. Avoid foods that decrease the LES pressure. Based on our list, include protein-rich meals to augment the less pressure. Avoid foods that are irritants, acid, alcohols, spicy foods. Although in some literatures, there are conflicting data on this, but nonetheless, if the patient observe and knows that this kind of food or drinks or any lifestyle or medications contribute to their GERD or NERD, they should avoid it or at best stop, so that to employ the treatment or to promote the treatment of the GERD. So the patients are also advised to eat in small meals and avoid overeating and eating prior to sleeping. So not to increase the production of acid at night. So stop smoking, as nicotine is one of the known chemicals or agents that can promote the effect on GERD. Alcohol and tight fitting clothes as well, especially in the abdominal area. So especially when sleeping, it is advisable to wear comfortable or good fitting clothes. And of course, to avoid medications that are known to be irritants, such as NSAIDs, and should only be taken with consultation, or if GERD is observed, the patient can consult the doctor for other recommendations of NSAIDs that have less gastrointestinal effects. So these are again the different pharmacological options. You have discussed this already in your pharmacology, so I'm giving you the opportunity to read in our references and evaluate the highlights on this part. So in terms of the therapy, combination therapy with an acid suppressing agent and promotility agent or mucosal protectants are the logical approach to the GERD. So normally, maintenance therapy can also be observed if there's a um, intention to prevent the complication and worsening of esophageal function, especially in the presence of other diseases that causes the GERD. So it may be required to have a long-term treatment in coordination with the treatment for the main condition. Now, for the evaluating outcome, so we monitor the frequency and severity. So the symptoms, we educate patient on especially the triggers for the GERD and the other non-pharmacological modifications or therapy. Evaluate patients with persistent symptoms, also to assess if there's a possibility of complications, further strictures, and monitor patients, of course, in with the adverse effects of the medications, especially if meds are to be used on a long-term basis. Now we move to PUD or peptic ulcer disease. So PUD refers to a group of ulcerative disorders of the upper gastrointestinal tract that require acid and pepsin for their formation. So normally, when we talk about PUD, the defect is mostly found in the gastric or the duodenal mucosal wall that can extend to the muscularis mucosa or even the deeper layers of the submucosa. So in PUD, it is a significant cause of morbidity and associated substantial healthcare costs, especially if there would be perforation or complications. So although some of the etiologies of PUD, we have H. pylori, NSAIDs, and stress-related mucosal damage, these are treatable. However, if left unmonitored or unevaluated, it can lead to complications such as bleeding, perforation, and even obstruction. And to add still is that for the H. pylori, H. pylori is considered now as a carcinogenic agent. So that's why cases of PUD should be monitored because in some of the studies, they have noticed that PUD, especially H. pylori related, are associated with possible development of gastric cancer. So etiology again is we have Helicobacter pylori. So this is a bacteria wherein or a microorganism that normally causes gastritis, which eventually may develop to systemic peptic ulcer disease. For NSAIDs, normally those using NSAIDs chronically or as part of their regimen, we would observe such treatment in the elderly population since some of the conditions in the elderly population would require maintenance treatment with NSAIDs. We also have the stress-related mucosal damage. This frequently occurs in critically ill patients since the mucosal defects are caused by possible gastric mucosal ischemia and intraluminal acids. So, in many cases, this can also be related to physiological stressful situations. Uh, SRMD may lead to sepsis, organ failure, and critical conditions, especially in the elderly patient. We also have the Solinger-Ellison syndrome. This is a gastric-producing tumor, also known as gastrinoma. So this results in hypersecretion of gastric acid, which causes diarrhea and malabsorption. Eventually, it can lead to ulcer formation and possibility of perforation and bleeding. So other causative agents, we can have cigarette smoking. So still, no, similar to what we've mentioned in GERD. Um, and also the dietary factors such as coffee, tea, alcohol consumption, spicy foods, and the like. So, but take note that in the dietary aspect or the dietary factors, they are more considered as risk factors to development and worsening of PUD. Now, for the pathophysiology, it includes the following. So, we have most peptic ulcer normally occurs in the presence of acid and pepsin. When Helicobacter pylori, NSAIDs, and other factors would disrupt the mucosal defense and healing mechanism of the GI. So, increased gastric acid secretion may occur with duodenal ulcers, but patients with gastric ulcers usually have normal or reduced rates of acid secretion. Now, normal mucose defense and repair mechanisms include mucose and bicarbonate secretion. So, intrinsic epithelial cell defense and mucosal blood flow. Now, maintenance of the mucosal integrity and repair is mediated by endogenous prostaglandin production. Now, in the event that patients take in like NSAIDs, which basically disrupts the prostaglandin production, so the mucosal defense and repair would be affected. Now, in the case of H. pylori, it causes mucosal inflammation. Thus, the mucosal inflammation will cause mucosal injury, and that would expose or allow for the development of ulcers due to the exposure to acid and less mucosal protection. So for our NSAIDs, normally we have aspirin because of their mechanism. They affect the prostaglandin. They also cause direct and local irritation on the epithelium. And basically, they can promote inflammation in terms of excessive use. So here is a comparison of the characteristic of the H. pylori induced, the NSAID induced, and the stress-related mucosal damages in terms of condition, site of damage, intragastric pH, symptoms, ulcer depth, and GI bleeding. So for the clinical presentation, we have dyspepsia and mild epigastric pain, uh, described as burning, knowing, and aching. Epigastric pain with duodenal ulcer typically occurs 1 to 3 hours after meals or at night. Pain with gastric ulcer occurs often aggravated with food, since if you can see, if the ulcer is within the stomach, so if the patient take in food, so the ulcers would be more exposed to the food and acid, so the pain is aggravated. It is described as burning or feeling of discomfort within if it's an abdominal pain, and the pain severity often fluctuates and can be characterized from dull to sharp, especially for gastric pain. So there can also be symptoms of heartburn, belching, bloating, and nausea and vomiting. For the signs, weight loss can be associated since nausea and vomiting can be present. Complications such as bleeding, perforation, and obstruction may occur, and this can be confirmed via endoscopy. Alarm findings in the family history, such as upper GI malignancy, unintentional weight loss, overt GI bleeding, iron deficiency anemia, progressive dysphagia, odynophagia, early satiety, permanent vomiting, palpable mass, or lymphadenopathy are red flags to PUD. So for the diagnosis, we have radiologic, endoscopic, non-endoscopic procedures, serologic, and stool antigen. So for radiologic, these are for X-ray. So this can also be associated to identify the uh, what they call this, the ulcerations found in the GI tract. For endoscopic, this is for endoscopy. This is much preferred as to navigate the gastrointestinal tract. For non-endoscopic procedures, we have um, several methods. So we also have serologic tests for the presence of H. pylori and other causes, and stool antigen assay. So this is the algorithm of treatment for PUD. So for the class, I want you to navigate this algorithm to appreciate the way on how medications are being initiated in terms of the cause, if it's NSAID-induced, if it's H. pylori-induced, or if it's SRM. So I will leave you with the assessment of this one. And then for the updated management of H. pylori infection, in a recent guideline, I believe this is in 2017, these are the recommendation. We have the clarithromycin triple, which is a combination of PPI, clarithromycin, amoxicillin, or metronidazole. We have the bismuth quadruple therapy, or the BQT. So this would include PPI, bismuth subsalicylate, tetracycline, and metronidazole. And then we can also have concomitant, such as the use of PPI, clarithromycin, amoxicillin, and nitroimidazole instead of metronidazole. For sequential, we can have PPI plus amoxicillin, then PPI, clarithromycin, and nitroimidazole. And for the hybrid, we use PPI and amoxicillin, and PPI, amoxicillin, clari, and nitroimidazole. We also have the levofloxacin triple, the levofloxacin sequential, and the load. Load means levofloxacin. O is for the PPI, so representing omeprazole. Nitazosanide for the A, and doxycycline for the D. So this is the treatment of Helicobacter patients recommendation with prior failure attempts. So for ACG, they recommend the bismuth quadruple therapy. It can also have the levofloxacin therapy and the concomitant non-bismuth quadruple therapy. So the others for the clarithromycin, high-dose dual therapy, and rifavitin therapy are suggested. Right? So this is just a continuation. Right? So for the recent updates on H. pylori PUD, the empiric choice is the bismuth quadruple therapy. Meaning to say, when we say empiric, the patient is still being tested for the presence of H. pylori, but the treatment is already started. Then once confirmed, they can go for dual therapy with high doses of PPI and amoxicillin. Also, one of the latest updates is the approval of the 2019 approval of US FDA of the drug Talicia, which is a combination of omeprazole, rifabutin, and amoxicillin. This is the first and only FDA-approved rifabutin-based H. pylori therapy. We also have vonoprazan. Vonoprazan, if you can recall, is an acid suppressor with the mechanism of a potassium competitive acid blocker. So this is first in the class, and this is usually the most extensively studied PCABs na tinatawag. So in this, there are clinical trials that includes treatment with vonoprazan and amoxicillin for the PUD. Another is probiotics. Although the role of probiotics in treating PUD in terms of H. pylori is they have insufficient data uh, to date. However, probiotics may offer significant potential in the treatment, but it needs more studies no, to elucidate the better effects against H. pylori. And then there is also a development of an H. pylori vaccine. However, the development has little success over time. So it's still in the development stage. Now, for the management of bleeding ulcers, so first the recommendation is to conduct endoscopic evaluation of therapy. And then we have the doctor must have to will evaluate the high risk stigmata. Meaning to say, if there's an active hemorrhage, there's a 90% risk of rebleeding. If there are visible vessels, that would have a 50% risk of rebleeding. Sorry. And if a fresh overlaying clot, there's a 30% risk of bleeding. So this is important because this would also be the basis for the duration of the treatment and the combination of therapies. So in certain cases, they use hemoclips in order to aid in the bleeding or to hold the bleeding. And then urgent esophageal gastroduodenoscopy are also advised. Acid suppression is one of the recommended treatment or general pharmacologic medical management for acute bleeding of ulcer or peptic ulcer. So this would reduce the gastric acidity and eventually that would improve hemostasis at the site. Then for management of NSAID-induced ulcers, in many cases, if the patient is positive to H. pylori, it is highly recommended that NSAID therapy should be discontinued. Now, for NSAID therapy is a must, meaning if it's needed by the patient, like for example, if the patient is suffering from pain-related condition that NSAIDs are recommended as maintenance therapy, then that would equate to adding proton pump inhibitor as a maintenance therapy as well. So primary prevention of NSAID PUD includes that the patient is opted to be treated with NSAIDs that have selectivity, such as the COX-2 selective inhibitors, which are known to have less effects on the GI tract or GI bleeding. However, what we need to take note of that is the one of the known side effects of COX-2 inhibitors are in the cardiovascular system. So we need to have a balance of which. We also look for prophylactic regimen or preventive therapy. Normally, patients with NSAID-induced ulcers are required to be placed on misoprostol, omeprazole, or lansoprazole as treatment options. So who are those patients with are candidates to prophylactic or preventive therapy of NSAIDs? Those with NSAID-induced ulcers who required chronic daily NSAID therapy, those older than 60 years old, those who had history of ulcers, and those who had concomitant steroids or anticoagulant treatment. And last but not the least, for ASA-induced ulcer, it was stated in a study in 2005 that aspirin-induced ulcer must or preferably can have or can be combined with esomeprazole or Nextube so as to address the possibility of preventing recurrent gastric ulcer bleeding. Now, there's also a study wherein they have combined esomeprazole and clopidogrel, and this has reduced the recurrence of peptic ulcer in patients with atherosclerosis who are in need of clopidogrel and also has a history of peptic ulcer. So this combination does not influence the action of clopidogrel on platelet aggregation. So for other therapy essential, we have to be very mindful of the complications of PUD such as perforation, bleeding. Consultation should be done. As pharmacists, we should advise our patients to regularly seek the consult from their doctors after they have completed a certain therapy regimen or symptoms persist. And long-term monitoring is required in terms of side effects of the drug and the response to the therapy. So that's all. Thank you.